Bismillahirrahmanirrahim. Assalamu alaikum wa rahmatullahi wa barakatuh. The topic of today's pathology lecture is hepatitis and cirrhosis. The ILOs on the slides are for both the practicals and the lecture, so I'll just go through the ILOs of the lecture today to demonstrate the knowledge of liver pathology in the viral hepatitis and in cirrhosis. Liver is primarily affected by four major diseases. They are called major primary diseases of the liver: viral hepatitis, alcoholic liver disease, non-alcoholic fatty liver disease, hepatocellular carcinoma. There are some diseases of the body which also affect the liver. So they are called major secondary diseases like cardiac decompensation, disseminated cancers, and extrahepatic infections. This is a very important table, although you will be doing more in detail about the functions and these things. These laboratory evaluation of liver disease are called liver function tests, LFTs. We have divided them into small groups. The first group are the enzymes which are important for looking into the integrity of the hepatocyte. If they are elevated, then we will come to know that the liver cells, the hepatocytes, are damaged or they are dead. These are the three enzymes: AST, ALT, and LDH. In acute hepatitis, this ALT is most important and is maximally elevated. The second important group is the substances which are normally secreted in the bile. The bile is produced by the liver, and we know serum bilirubin metabolism. So whenever bilirubin is elevated, that means there's problem in the liver function. Third group is of plasma membrane enzymes which are associated with the bile canaliculi. These two enzymes, alkaline phosphatase and gamma GT, are elevated when there is obstructive jaundice, because they are released when the bile canaliculi, which takes the bile towards the gallbladder and towards the duodenum, they are damaged, then these two enzymes are elevated. Then finally we have the substances which are secreted in the blood, produced by the liver. Liver produces albumin, which is a very important plasma protein, and if liver function is affected, then serum albumin level is decreased and patient will have many problems, including generalized edema. Then clotting factors are produced by liver, prothrombin and other clotting factors. So we look at the prothrombin time, clotting time, etc., to assess the function of the liver. Finally, ammonia, which is produced in the GIT, is a kind of a toxin. When it reaches the liver, it is detoxified by the liver, and if it is not detoxified, it circulates and reaches the brain and can cause brain damage, can cause encephalopathy, can cause coma. I will not touch, of course, you will be taught more in detail about the hepatitis screen test, about the viruses. So now coming to the actual main topic. Viral hepatitis is because of the hepatotropic viruses, hepatitis A, B, C, D, etc. They are called tropic because they have particular affinity for the liver cells. But we should also know what other viruses can be affecting. What other viruses affect the liver which are not hepatotropic. These are the systemic viral infections that will also affect the liver. There are three which I have mentioned, and we can ask even the MEQs, etc. Epstein-Barr virus, cytomegalovirus, and the yellow fever virus. These are the viruses which are not hepatotropic, but they can infect the liver along with the other systems of the body. When there is viral hepatitis, the person infected by viral hepatitis can go through clinico-pathological syndromes. There are many syndromes, but we will do the four important ones. Clinical pathological syndromes of viral hepatitis. First two are the acute asymptomatic and acute symptomatic hepatitis. As the name is suggesting, acute asymptomatic infection with recovery occurs when patient does not have any symptoms, but there is serological evidence that patient was infected by hepatitis virus. So acute asymptomatic, no symptoms. But the main one is the acute symptomatic hepatitis with recovery is the one which we will do now. But the other 3 and 4 we will do after these. What is the pathogenesis? How the virus, they produce damage or help in the damage of the hepatocytes. What is the pathogenesis of viral hepatitis or viral inflammation of the liver cells? So when the virus enters the hepatocytes, when it causes the infection, it will not cause by damage of the cell by producing toxins or directly killing the hepatocyte. The virus does not do anything like that. What it does is that it only changes the antigenicity of the hepatocytes by production of these molecules on the surface. These molecules are the histocompatibility molecules. This is MHC1 molecule, major histocompatibility class 1 molecule. By formation of this molecule on the surface, now this hepatocyte becomes different, and antigenetically it becomes different. It becomes an ajnabi. It's not the self of this human. It will act as a foreign body or foreign cell when any lymphocyte comes. Suppose this CD8 T lymphocyte which is passing by this, and it is a lymphocyte which is checking whether all the cells are okay or not. It look at this molecule and thinks that this is not our cell, this is a foreign cell. This is coming from outside. Because of the presence of this new molecule, it will now recognize it, and then it will cause death of this cell. It will cause cytotoxic killing of the cell by the CD8 T lymphocyte occurs, because when the infection occurs, the antigenicity of this cell is changed by MHC class 1 molecules. This is how the cell death occurs in viral hepatitis due to these viruses. There are two main general morphological features of acute and chronic hepatitis. We are doing it together to understand in a better way. Now we are using acute and chronic together. Some points of chronic we will do later, but here, when we are trying to understand the morphological features, we are describing them or trying to understand them together. The one on the left is for the acute, and one on the right is for the chronic hepatitis. It is better to understand through the diagrams, and very nice diagrams from your textbook. It will make you understand easier as compared to the H&E slides, which become histology slides, become difficult. So you can see there are many changes that occur during the acute hepatitis, many changes. You can see the long list here, and all that we'll do slowly and slowly in detail, don't worry. We first do the acute hepatitis. The same things I've written here, 8 changes that can occur. But if we start doing them all, it will be very difficult for you because this is not at this undergraduate level so important. Only these 2 are important for you to understand about the necrosis and inflammation in acute hepatitis. This is what I'm going to explain to you now. In acute hepatitis, what happens with the necrosis and what happens with the inflammation. We are less concerned with the long list of other changes. Similarly, in chronic hepatitis, along with necrosis and inflammation, we have fibrosis is also important. And then there are other total 10 things which we are not concerned at this stage at undergraduate level. But we may ask you, some good students can answer these later on, we'll tell you. So what happens with necrosis and inflammation in acute and chronic hepatitis? What are the changes related with necrosis and inflammation? How it happens, how it starts, how it ends. Inflammation and necrosis, they go together. Whenever there's necrosis, there will be inflammation. Whenever there's inflammation, there will be necrosis. So it is described together. The first step, whenever the infection starts, whenever the hepatitis starts, it starts in the portal tract. You know the diagram and histology. This is the portal tract, which contains the bile duct and the portal vein and the hepatic artery. So this is the portal tract. The inflammation starts here. We call it portal inflammation. This is the simplest or the earliest change that is also graded from grade 1 depending on the severity of the infection. So I repeat, this is important that whenever the infection starts, it starts in the portal tract. The necrosis and the inflammation starts in the portal tract. That is why it is called portal inflammation. This is grade 1. Then the second, when the inflammation increases, when the severity of the disease increases. Now inflammation from here, from the portal tract, it now comes outside in the periportal area. The area next to the portal tract, we call it periportal area, and now the inflammation is in the periportal area. There are two other different names for this periportal inflammation. One is called interface hepatitis, because this inflammation occurs at the interface, the junction between the portal tract and the hepatic nodule. So that is why it is called interface. Then it is called piecemeal necrosis because only in the beginning, only small areas, small pieces of necrosis and inflammation occur. So they are also called piecemeal necrosis. I thought I'll let you know because when you read the reports of liver biopsy, then you'll see all these terminologies used by the pathologists. But for undergraduate level, the grade 2 inflammation is periportal inflammation. Then third is lobular. You see, when the inflammation increases, grade 3 is lobular inflammation. Some lymphocytes and macrophages, they are present because of necrosis. So inflammation becomes lobular, inside the lobule. This is a grade 3. Finally, confluent. Confluent means combined. So small areas, they combine form larger areas. So that is a confluent inflammation, and the highest grade 4 inflammation is called confluent inflammation, a combined inflammation. Some people also call it bridging. We'll see this word bridging in the next slide. And bridging necrosis can occur from the portal tract up to the central vein. So there are 4 stages, 4 grades. These are the grades, not stages, I'm sorry. So grades are 4: portal inflammation, periportal inflammation, lobular inflammation, and confluent. When they combine together to large areas are formed. That's the severe grade 4. So this happens in the acute as well as in the chronic hepatitis. But in chronic hepatitis, we see fibrosis also. We don't see fibrosis in the acute hepatitis. Fibrosis is present only in the chronic hepatitis, and it goes through the same pathway. In the first stage, in the beginning of the chronic hepatitis, the fibrosis occurs only in the portal area. We call it portal fibrosis. Now this is staging. This is not grading. If you recall your tumors like malignancies, they are also graded under the microscope, and we also see their stage, like it's in the mucosa, submucosa, musculus propria, serosa. Similar is the case here. So in stage 1, the fibrosis is only in the portal tract. In stage 2, it is in the periportal area, periportal fibrosis. The third stage is the bridging fibrosis. Fibrosis which is present after bridging necrosis. It extends from the portal tract to central vein. So this is the bridging fibrosis, stage 3. And finally, a time comes when cirrhosis occurs. We'll see that, of course, in greater detail. So 4 stages of fibrosis: portal fibrosis, periportal fibrosis, bridging fibrosis, and cirrhosis. And the diagram is showing other changes also. We are not concerned with that. Just I'll mention about these important ones. This is just maybe Dr. Aladdin will tell you more in the practicals. If not, these are present in your textbook. That is why I'm mentioning that when there's hepatitis B infection, we are able to see some changes. We call them ground glass hepatocyte. The cytoplasm of the hepatocyte looks like ground glass. This is a feature of hepatitis B. We then do the special stain, immunostain. We use the antibody against this antigen, the surface antigen of hepatitis B, and then it will become positive. Brown is a positivity. We come to know that this liver biopsy, this specimen is positive for hepatitis B. Just for interest, I tell you that hepatitis B surface antigen, HBsAg, is also called Australia antigen. Hepatitis C is the second chronic disease. So one is hepatitis B and hepatitis C. They cause chronic hepatitis. Hepatitis C has 3 special features: collection of lymphoid aggregates within the portal tract. This is the lymphoid aggregate here. There's proliferation, reactive proliferation of the bile ducts, reactive changes in the bile ducts. There are increase in the number of bile ducts in hepatitis C. And there's fatty change. Steatosis means fatty change. The fatty change is macrotype, large molecules of fat. So these are the 3 features of hepatitis C. We may ask you in the quiz, etc., simple questions. What are the pathological features, special features of hepatitis C? After these acute and chronic symptomatic and asymptomatic hepatitis, we come to the fulminant hepatic failure, also called fulminant hepatitis. There's extensive hepatic necrosis. Fulminant itself means very severe, very strong, very severe inflammation and necrosis of the liver. This occurs rarely, sometimes it occurs, but this is defined as there's production of hepatic insufficiency. The liver cannot perform its function, and it progresses to hepatic encephalopathy, means it is affecting the brain. Patient may go into the coma within 2 to 3 weeks, within just 2 or 3 weeks, in a person who never had a chronic liver disease. Chronic liver disease may sometimes go to slowly go to hepatic coma or encephalopathy, but if it is happening directly within 2 to 3 weeks, only then we can call it fulminant hepatic failure. So it is the hepatic insufficiency that progress to hepatic encephalopathy within 2 to 3 weeks in individuals who do not have chronic liver disease. I hope it's clear. Then viral hepatitis is responsible for only 12% cases of hepatic failure, fulminant hepatic failure, out of which 2/3 are caused by hepatitis B and 1/3 by hepatitis A. These hepatitis viruses can cause only 12% of the cases of fulminant hepatic failure. Just for information, about 50% cases are due to paracetamol toxicity, acetaminophen toxicity due to accidents or by suicidal attempt. So what do you see in fulminant hepatitis? You see that the liver, which is about 1.5 kg, 1500 grams, becomes almost half the size. The liver shrinks. It becomes a limp organ. It has a wrinkled capsule just like the skin of an old person. Under the microscope, we see complete destruction of hepatocytes in contagious, means continuous lobules, and the whole system is collapsed. The reticulin framework is collapsed, but you can see preserved portal tracts. These are the changes just to describe how this fulminant hepatitis looks like. Initially, interestingly, this is something very odd. We cannot explain that you don't see any inflammation. Very little inflammation occurs, very little reaction occurs. There's direct necrosis of the hepatocytes, but if the person survives, if there's survival for several days, only then inflammation will come. Inflammatory cells will come after survival of the patient. If patient survives for a few days, several days, then only they will come and do the cleanup of the necrotic tissue. This is a gross picture of the massive necrosis or fulminant hepatitis. Liver is very small, half the size of the normal liver. It is bile stained, soft and congested. This is important. I'm showing you the necrosis. This is how the necrosis looks like. This is our massive necrosis, and here some of the hepatocytes are trying to regenerate. That is the histology of the massive necrosis or fulminant necrosis. We finally reach to the fourth type of clinico-pathological syndrome of viral hepatitis, that is the chronic hepatitis. Chronic hepatitis may lead to cirrhosis or it may not lead to cirrhosis. When it leads to cirrhosis, the type of cirrhosis we call is post-necrotic cirrhosis. The name is suggesting that this type of cirrhosis will occur after necrosis. Why it occurs, how it occurs, just briefly now, that there's continuous loss of hepatocytes followed by fibrosis, and slowly the whole liver is converted into cirrhotic liver, cirrhosis, which shows irregularly sized nodules separated by fibrosis or scars. In about 20% of the cases, the cause of cirrhosis cannot be determined. We call it cryptogenic cirrhosis. So now we have reached the second part of the lecture about the cirrhosis, and this is just the title picture of the second part. So what is cirrhosis? Before that, the frequency of cirrhosis, it is the 12th most common cause of death in the developed countries, and the chief causes of cirrhosis are alcohol abuse, viral hepatitis in our part of the world, and NASH. We just saw non-alcoholic fatty liver disease. So after that non-alcoholic fatty liver disease, when there's inflammation, we call it NASH, non-alcoholic steatohepatitis. Inflammation of the liver due to fat, and the cause is non-alcoholics. We call it NASH when it is progressed from NAFLD, which we have done in the beginning of this lecture. Other etiologies of cirrhosis include biliary diseases, drugs, and iron overload like hemochromatosis, which is a genetic disease. To qualify the definition of cirrhosis, there should be three important morphological features. There should be three features, only then we can call it cirrhosis. The first one is bridging fibrous septa. These are the fibrous tissue, the collagen tissue, which extend from one portal tract to another portal tract, or from one portal tract to the central vein. So these are the bridging fibrous septa. One feature, the first feature. Fibrosis is a key feature, and it will tell us that there was necrosis going on, which is now being followed by fibrosis. So it's a key feature of progressive damage to the liver. Second important feature of the definition of cirrhosis is that there will be parenchymal nodules, nodules of hepatocytes. These are the hepatocytes which are encircled by fibrous tissue, fibrosis. These nodules of hepatocytes may vary in size from very small, less than 3 millimeter in size, also called micronodules, to large nodules which are several centimeters, and they are called macronodules. In previous times, they used to differentiate between micronodular cirrhosis and macronodular cirrhosis, but now they don't do it. They feel that it's not so important to differentiate between the two. Why nodularity occur? Because whenever there is necrosis of the hepatocytes, the surrounding hepatocytes, they start regenerating. They have the power to regenerate when the need is arising, and then they regenerate as nodules and surrounded by scarring or fibrous band, so it looks like a nodule. So nodularity is because of the regeneration of the hepatocytes surrounded by scar tissue. The third feature is that this condition should affect the whole liver. The parenchymal injury and fibrosis should be diffuse, extending throughout the liver. Focal injury with scarring does not constitute cirrhosis. If there is a fibrosis or nodularity in small area, only in the left lobe or in the right lobe or apex, then it is not cirrhosis. Cirrhosis should affect the whole liver. Now we can explain on this picture. On the right side, upper right, is the gross specimen of the liver, which is showing nodularity all over, both the lobes and the caudate lobe, etc. The whole liver is showing nodularity. And when you make a section, make a slide, and do the special stain, this is called trichrome stain, you can see the collagen as blue in color, and you can see the nodularity because of that special stain. Pathogenesis, how cirrhosis occurs. The central pathogenic process in cirrhosis are three. There are three pathogenic processes in cirrhosis. Number one, death of the hepatocytes, followed by deposition of the extracellular matrix or fibrin or fibrin or fibrous tissue, and after that, vascular reorganization. The circulation reorganizes because of this deposition of the extracellular matrix. Now we'll go to the normal picture. This is the normal picture of a liver diagram. It's a diagram to explain the pathogenesis of cirrhosis. We start with the bottom. These are three hepatocytes. Between each hepatocyte, two hepatocytes, there is a bile canalicula, the yellow color. Then as we go above, this dark brown area is a special area called space of Dis. Some people pronounce it Dis or Dissi. I saw on the YouTube also both the pronunciation are present, but he was a German histopathologist who has discovered this small space between the liver cells and the sinusoid. The sinusoid is just like the blood circulation in the liver happens in the sinusoids. It's not in the capillaries. They are in the sinusoids. They are open, larger spaces which have fenestrations. The endothelial cells lining the sinusoid, they are very large spaces called fenestrations. And the sinusoids also have these macrophages, the defense cells. Here they are called Kupffer cells. Interestingly, between the sinusoids and the hepatocytes in this space of Descemet are special cells called stellate cells. Stellate cells, they are quiescent in the normal state. They are sleeping. Some people say they are important in the storage of vitamin A. So they are not doing anything here. This is the normal histology. Most important is that this space is covered, contains delicate collagen fiber. This is a very thin, small collagen. I think it's collagen 4 or 5. So there are many types of collagens. So this is a delicate collagen, and it's not affecting any diffusion of substances between the blood and the hepatocytes. This is the normal picture. Now, when there is damage to the liver cell, this liver cell is dying. It is apoptotic hepatocyte. When it dies, it will produce, of course, reaction, and the macrophages become active. It will produce all these cytokines for proliferation, for contraction, for chemotaxis, fibrogenesis. All these will start coming out of this Kupffer cell or the macrophages, and then it will activate these stellate cells. It was sleeping in the beginning, now it gets activated, starts dividing, start producing collagen also, and this collagen is the thick one. It's the collagen 1 and 3. I think these are the thicker bands of collagen. Now this fibrogenesis will affect the function of diffusion mainly, and it will not allow the nutrients and the toxins to go, all the material, the function of the hepatocyte is affected because of the thick collagen produced by the stellate cells. So now in the first stage, the fenestrations, which are the openings in the endothelial cells of the sinusoids, they are normally large holes. These are the fenestration in the sinusoidal endothelial cells. But because of the deposition of the thick collagen in the space of Descemet, these fenestrations closed. They get closed, and that will affect the function of the sinusoids. The exchange of the solutes between the hepatocytes and the plasma cannot occur because now the fenestrations are closed because of the thick collagen. This is the first step that occurs. Now, second important change occurs in cirrhosis is that the shunting of circulation. Normally, the vascular architecture of the liver is, we saw that it's directed from the sinusoids to the, through the space into the hepatocytes, but due to continuous damage and scarring, this cannot now, blood and these substances cannot directly pass to the liver cells, so new vascular channels are formed. These vascular channels are formed in the fibrocepta. Although it's a reactive thing, but unfortunately, lot of blood also is shunted. It's not reaching the parenchyma. It's going through the fibrous tissue from the portal tract to the central vein directly. So there's shunting of the blood. Blood cannot directly go from the sinusoids into the hepatocytes, like from the vertically from the sinusoid into the hepatocyte, but it's going like horizontally from the portal tract to the central vein. So there is a lot of shunting. All the blood is not reaching, so that will of course affect the function of the hepatocytes. The vessels are now directly going into the central vein. Third step is nodularity. As we have seen that whenever there is damage to the liver, the hepatocytes, they will try to regenerate and proliferate, and in this process they form spherical nodules. Because they are surrounded by fibrous tissue, they cannot form proper structure of the liver as normal lobule, but they form spherical nodules because they are surrounded by thick fibrous septae. So the third step in the pathogenesis is the formation of the nodularity. So the final outcome of these changes is that fibrotic nodular liver is formed, in which the delivery of blood to the hepatocyte is severely compromised. The blood cannot reach the hepatocytes, and thus the hepatocyte cannot perform normally. So finally, we come to know that there's a nodular liver, fibrotic liver, in which the circulation is not proper, and the blood is directly shunting into the central vein and the hepatic vein, and that will affect the liver, compromised. What are the symptoms of cirrhosis? In the early stages, when there's only little bit of fibrosis, we call it compensated liver. Liver is still doing its job. It is compensated. Patient is asymptomatic, except some non-specific changes like weight loss, weakness, fatigue. So in the early stage, the cirrhosis and the liver is compensated. But later on, when there's a lot of fibrosis, the function is decompensated. Now it cannot function properly. The liver cannot function properly. We call it decompensated cirrhosis. The first one is jaundice, important feature, important symptom of cirrhosis and liver disease is jaundice. Bilirubin metabolism is affected, plus pruritus. Pruritus means itching of the skin, itchy skin. Pruritus is itching. This is because of presence of bile salts, increased bile salts in the circulation. Normally the bile salts and bilirubin, etc., they should go through the bile into the duodenum and then go out, but it does not go out and it remains in circulation. The bile salts, they cause pruritus, itching. Then ascites will occur because the liver is not producing albumin enough, and itself the portal hypertension will cause ascites. Ascites means fluid in the peritoneal cavity. Next is the hepatic encephalopathy. Damage to the brain, the function of the brain is affected. The pathology of the brain due to liver is hepatic encephalopathy. In the beginning there will be confusion, but later on there will be coma. Easy bruising can occur because we know that liver is also important in producing the clotting factors. So bleeding in the skin or the mucosa is called easy bruising. So these are the symptoms of cirrhosis. Okay, to diagnose cirrhosis, liver biopsy is considered as a gold standard. It takes tiny piece of liver tissue by needle biopsy, and then we see it under the microscope. The lab findings will show, of course, elevated bilirubin and elevated enzymes. These are called LFTs. All these we have just gone through in the beginning. Important thing to note that in cirrhosis, AST is greater than ALT. In the active disease, in the beginning, acute and chronic hepatitis, ALT is more than AST, but here AST is greater than ALT. Then of course we can do the radiological studies like fibroscans and elastography, etc. for confirmation. Complications of cirrhosis: there is decrease in the liver function, and liver is a very important organ, chemical factory, detoxifier. So detoxification effect is also decreased, function is decreased, and most important toxin we saw in the beginning was ammonia. Ammonia is produced in the GIT and it is metabolized or detoxified in the liver. But if it is not detoxified, it goes into the circulation, into the brain. It produces hepatic coma and it produces asterixis. Asterixis means tremors of the hand. So there are different types of tremors you must have done in mind and movement. So one specific tremor of hepatic coma is asterixis. Another important function of liver is to metabolize estrogen. When estrogen metabolism does not occur, there is hyperestrogenemia, increase in the estrogen in the blood, that will lead to three important clinical findings. Gynecomastia means increase in the size of the breast in the males. The males develop the breast because of the increase in the estrogen in the circulation. So that's called gynecomastia. The others are spider nevi, spider angiometa, and palmar erythema. These are also the features of excessive estrogen in the blood. You remember them in case you get an MEQ on it. Bilirubin, we all know, is very important. Very important function of liver is to metabolize the bilirubin, to conjugate the bilirubin. Normally when it is produced, it is unconjugated. Liver conjugates it. So whenever this liver function is affected, the unconjugated bilirubin increase in size, and it will cause different problems, which we will do by other teachers. Decreased albumin production will cause hypoalbuminemia and edema. Decreased clotting factor production will cause problems in the coagulation, bleeding disorders, etc. And finally, this is an important slide of portal hypertension. We know about portal circulation. Liver is in the portal circulation, or whatever the food and everything from the GIT is collected through the portal vein into the liver. It gets metabolized, and whatever it is done, we all know about its importance. Portal circulation, the hepatic portal system, is connected with the systemic circulation at three places: at the lower end of esophagus, in the umbilical region, and in the anorectal region. These are three places where the portal circulation of the liver meets or anastomoses with the systemic circulation. So whenever there's increase in the portal circulation pressure, portal hypertension, because of all these fibrosis in the liver and shunting of the circulation, there is portal hypertension. This will lead to these four things. One is ascites. Ascites, collection of the fluid in the peritoneal cavity, which occurs due to portal hypertension and also due to hypoalbuminemia. Ascites, collection of the fluid in the abdominal cavity, in the peritoneal cavity. Portosystemic venous shunts. As I told you, there are three shunts. So if there's portal hypertension, there will be esophageal varices. The veins in the lower end of the esophagus get engorged, they increase in diameter, and they can rupture and cause hematemesis, vomiting of the blood, and it's an acute emergency to have esophageal varices. Patient can get hemorrhoids due to engorgement of the venous channels in the region of the anal canal, and this is also important. We call it peri-umbilical caput medusae. Around the umbilicus, the veins, they radiate like this. The caput means head. Medusa was one of their god, Yunan, from Greek god and goddess. I think she lady, yes. So Medusa was a lady, goddess, and she had snakes on her head. So these veins, they look like that caput medusae, head of that Medusa, goddess of Greece. So these are three features due to portosystemic venous shunts, esophageal varices, caput medusae in the periumbilical region, and hemorrhoids. These are due to portosystemic venous shunts. Then because of the portal hypertension, splenic vein is also a part of portal circulation, so there is congestive splenomegaly, increase in the size of the spleen. Spleen increase in size due to portal hypertension. And finally, we have seen hepatic encephalopathy because of the function affected. There is increase in ammonia, and there will be encephalopathy, hepatic coma because of the portal circulation. My reference mainly is the Robbins Basic Pathology, and I've made a PDF of these pages, and I'll send it to you, and then you can circulate. It's the additional resource also. I've done it, and also seen these videos from osmosis.org on the YouTube, viral hepatitis and the cirrhosis, and took some screenshots, all this from them also. You can see them. You will enjoy because they are the videos, and you will understand better. And any questions, of course, I won't be available till maybe Monday afternoon. You can send me your questions by WhatsApp. Thank you very much. Assalamu alaikum wa rahmatullahi wa barakatuh.